Hey guys, this is Greg McKettrick. I'm the clinical liaison for Men's Health for Revelation Pharma, and this is my October presentation. We're going to cover a little bit about men's hormone therapy. This is our legal page, our disclaimers for y'all to peruse at your discretion. So what I would like to try and cover today into a little bit of detail about the physiological changes that go on as we see the age-related reduction in hormone production and the effects it has on the system. Also, hormone testing, what is available to us, what is practical, and really what is the best choice for patients. And then therapeutic goals. So, what are we looking at on the individual patient, not just a number on a report, but subjective findings and what their goals of therapy are. And then hormone levels and the effects. So again, as the decline in production kicks in, what's happening, and then as we start to reestablish levels. And also very important, the therapeutic options and the various dosage forms we have at our disposal. So, physiological changes. As we know, hormone production drops off as we get older, and there are substantial changes for obviously both men and women, but we're looking at men. So, what do we see predominantly? We see a lot of changes in terms of the presentation of the body, muscle mass. We see loss of bone, the increase in buildup of adipose tissue or redistribution of fat in the body. Sorry about that. Impairment of both physical and sexual functions. So common reports that I get from patients, I don't feel like I used to. My body doesn't look like it used to, and I can't perform like I used to. And I know we've all seen our fair share of the commercials and ads where you get a old sports star get on TV and say, you take this and you're going to feel great, and boy, she's going to like it too. Well, some of that we know is a little bit far-fetched, and that's why we really look at the basics in terms of hormone therapy. So talking about hormone testing. So for the most part, the dominant tests are going to be serum tests and saliva tests. I know personally, majority of the patients that come to me who have been treated or are under the care of a physician, they're getting serum testing done at a much higher rate than saliva testing. The doctor either has a lab in the office where they're doing their draw and then sending it off to LabCorp or what have you. But serum testing is invasive, obviously. It's a needle stick, even though it's not a big pain. It is invasive and it's expensive. Hopefully patients have insurance that covers this, but if not, it's pretty expensive stuff. And it does take time. You have to have a trip either to the lab or to the doctor's office, so it's not the most convenient thing in the world. As opposed to saliva testing. So again, saliva testing, very non-invasive, easy for patients to do, relatively inexpensive. Again, I said a patient-friendly test, so it's something that they can do throughout the course of a day, basically depositing saliva into the tube for the test. Also, for the benefits of the saliva testing, it's very sensitive, it's very accurate. We get a great read on what is the free hormone level or the bioavailable hormone level. Also, if a patient is using a topical hormone product or even a sublingual, you're going to get a much more accurate reading using the saliva testing. Again, bouncing back to the serum, if we're looking for really getting a idea of what's going on with the patient's hormone levels, you have a much more difficult time. You really have to time the test. They are reliable just to look at excesses or deficiencies in levels. And again, it is a little bit inconvenient and expensive, but it is a relatively simple procedure for them to draw the blood. Oh, talk about therapeutic goals. So, patients come in and obviously, like I said, they kind of have their reports of what's going on. They don't look like they want to. They can't perform like they used to, and things aren't working like they ought to. So what do we want to look at? Well, obviously, the patient's age is a huge thing to consider. Concomitant factors, other disease states, risk factors that may be involved in any particular patient. Looking at their report, their subjective report, or even objective reports in terms of specific symptoms they're presenting with. And very important to discuss with the patient what their actual goals of treatment are. Are they just looking for a little boost in energy? Is this libido? Is it really to change their body image? Are they looking to restart an exercise routine? Whatever the case is, consider their goals and discuss with them the available types of treatments that are available that we can offer. Common goals, again, the replenishment or maintenance of their hormone levels in their system. Again, as we age, everybody's levels drop if we don't do something to influence that. Improve their quality of life. So I put in here anti-aging, but really I guess my definition is aging well. So, aging and still being able to enjoy the things in life that really bring you pleasure. Improving the physical characteristics. Again, increasing muscle mass, increasing bone density, reducing the fat on the body, or again, redistributing muscle and fat. As we mentioned, better energy, sex drive, extremely important. Again, huge factors for quality of life. And not to be left out, cognitive function. For men with brain fog, it's a big issue. And also cardiac function is very, very strongly influenced by hormone levels. So what hormones do we really pay attention to with men and why? So pregnenolone. This is really the primary precursor hormone, generally referred to as the mother of all hormones in the system, or since we're talking about men, we'll call it the father of all hormones. A lot of downstream metabolism into the other hormones that we need. Testosterone, of course, that's the dominant male sex hormone. That's where you get your muscle mass and body image and sex drive. FSH and LH. So, again, look at patient's age in particular, but these are extremely important for maintaining fertility as well as feeding into production of testosterone. Prolactin, which again kind of works along the lines of enhancing the LH and important in overall function. Estradiol for men modulates sexual function, maintains bone density, heart health, brain health. So it's oftentimes thought of as more of a female hormone, but definitely important for men. Sex hormone, we really look at this for regulation of testosterone production and maintaining a good ratio, maintaining the levels in our body. TSH regulates all the hormone production through the system. Cortisol, our stress hormone, which again, it's great. It influences our inflammatory process, regulates blood pressure, regulates blood sugar, and influences our overall health. So, muscle mass, fat content, energy, immune, extremely important. Progesterone, again, another very important hormone for men. I particularly pay attention to it because of the functions that it plays in terms of inhibition of aromatase and 5-alpha reductase. And then DHEA, the hormone precursor, of course, for both testosterone and estrogen. And again, this is one that really significantly drops off with age. So by replenishing, we can boost the testosterone and the effects. So when initiating hormone therapy for patients, number one thing, I'll do your due diligence. Make sure that you're getting the labs, you're getting a full patient history, you know what their goals are, you know what their intent is in terms of child bearing or fertility issues. I refer to, when I'm talking to patients, a lot of times says, if you've got a terribly sprained ankle, it's all black and blue and swollen, and you went to the doctor and they just put an ace bandage on it and sent you home, you wouldn't be very happy because they didn't do an x-ray. They didn't look to see what was really going on in there just in case there was a deeper dive story. So this is kind of our work to do in terms of making sure that we're digging into the patient. Therapeutic recommendations for patients, we need to really look at both the numbers that we're seeing as well as the patient's report, their subjective findings. I like to always incorporate the kind of basics, the lifestyle benefits, diet and exercise, sleep, good supplements. If we can get patients to buy in on that level, then not only are they going to probably be more compliant with hormone therapy, but their outcomes are going to be much better. In terms of where the patient is, what's going on, obviously people jump in to different levels of the swimming pool. Some are just kind of wading in, very basic, looking to boost their effects. Others are more of a deep end patient right off the bat. So we need to look at the patient, the particulars, and make determinations based on the patient's circumstances on what options we're going to pursue and how we're going to initiate therapy. I'm big with obviously the whole fertility issue, and men always want to jump into testosterone replacement therapy for everything. I don't care if it's ED or weight loss or what have you. But depending on the age of the patient, you want to consider the options prior to initiating exogenous testosterone therapy. And we start using TRT, we are really going to shut down testicular function in the patient. So, whenever possible, let's look at using either HCG or clomiphene to jump those numbers up and see if we can make the effect that we need and maintain testicular function. And then, throughout the course of treatment, make sure that we are keeping an eye on all of the hormone levels. Obviously we're not just looking at a testosterone number when we're treating a patient because we know that there's a lot of downstream metabolism. Adjust dosing and even route of administration. You may find that a particular course of therapy just doesn't work for a patient, and whether you're going to change them to a topical from an injectable or vice versa, you just may see better benefit for an individual by changing things up. If you're starting TRT, big factor for me, I want to get them on the supplements. I want to get them on the natural aromatase inhibitors instead of waiting. We can always wait 6 months and then see if the estrogen's climbing up or DHT's climbing up. But, if we can do some of these things early on, why not? It just makes a lot of sense, and it's easy, and not terribly expensive for patients to pursue this on more the natural side. When we do need to become a little bit more aggressive, obviously we can use things like an anastrozole. I'm a big proponent, if we're doing TRT, especially with topical TRT, incorporate a little progesterone. Like 10 milligrams a day really does wonders in terms of being a aromatase inhibitor as well as a 5-alpha reductase inhibitor. So, this is real easy to do, inexpensive way to stave off any real problems. And again, I mentioned the other 5-alpha reductase inhibitors for DHT as well. So, a little bit more information about the individual hormones. So pregnenolone, again, mentioned it, primary precursor hormone, downstream converted into DHEA, testosterone, progesterone. Peak level in the body is, by age 30, and then drastic reduction with age. So up to a 60% reduction, and again, think of the downstream effect of that. Pregnenolone maintains the other hormone levels, which in turn supports the physical body activity, cognitive health, heart health, everything. It also is really great in terms of protecting our system. So, against toxins, against nutrient depletion, aging in general, stress. Depending on where you look, dosing really, really has a wide range. As little as 10 milligrams, and then some sources you'll look at will list using literally hundreds and hundreds of milligrams of pregnenolone. In reality, somewhere around 30 milligrams a day really is probably sufficient. When you get into much higher doses, you're getting some downstream conversion that may not be beneficial. Progesterone. It's actually a testosterone precursor in men. Low progesterone gives you a lot of the same symptoms that you get in general for patients who have low T. So something we want to take care of. We want to watch it. The other, again, the real benefit that I love about it is, incorporate it with TRT, because it helps to prevent the conversion into estrogen and DHT, and in a very simple way, very low dose. Literally just 10 milligrams topically a day. So if you're doing a topical cream, adding a little bit of progesterone in there is pretty easy. And then another age-related hormone, DHEA, precursor for testosterone and estrogen. By age 25, we are seeing the decline start. It's funny, we never measure, or generally we don't measure hormone levels in men when they're 18 to 20, 25 years of age to really see what their normal walk-around levels are. I get that question all the time. Guys say, well, I want to know what my normal level should be. Well, you can use anything to describe normal, but in effect, we'd have to have testing going back into their history to really know that. Not taking a whole lot of it can do a significant amount for the body. So 50 milligram to 100 milligram doses can really restore the natural level. It is metabolized through the system into testosterone, but it can also be converted into progesterone and estrogen. So again, important to really watch. A lot of times we will see the DHEA used with TRT, and there can be some justification for that, but again, you really have to make sure that you're watching the downstream effect. Are we metabolizing into other hormones instead? And of course, testosterone. So that's the big banger for us guys. Primary male sex hormone, sex drive, muscle and bone mass, cognitive, so brain fog, cardiac function, red blood cell production. And that magic number keeps showing up, age 30. So right in that 25 to 30 year old window, we really start to see in men that drop off occur. In testosterone, it's a more gradual drop, but you can see significant deficits as we age, and that has huge effects on the body. One thing I found really interesting, and some of this is more recent in terms of the studies, but we're seeing significant decline in testosterone in much younger patients, as young as 15. And the big factors involved in this are really the comorbidities, diabetes and obesity, um, huge factors. So we're seeing a population that the effects are being felt at a much earlier point of life, and that is something I really think we should pay more attention to. Um, like I said, we generally don't look at our levels when we're 20 years old, and maybe we should. So therapeutic options and dosage forms. I've talked a little bit about how we can incorporate things, especially into the compounds, but talking about testosterone in general for TRT. So testosterone injections, that's kind of the gold standard for most guys. They've been to the gym, their buddies are injecting testosterone, and that's what they want to do too. And it's fine. It has a lot of advantages. No risk of transference. So you're not going to inject and then rub up against a spouse or a child and transfer testosterone. Bypasses first pass metabolism. It is relatively easy to adjust the dose, but again, that does take doing the level monitoring. Um, Nice things about this, and again, I've talked with patients about this for a long time. I talked with a patient yesterday about this. They were started on testosterone injection therapy once a month. I haven't heard about this for decades, doing it once a month, but this guy was starting this just a few years ago for insurance reasons, getting injections of testosterone once a month. Like, oh my gosh. So, we really want to see more frequent dosing. I'm a big advocate of even doing the breaking it down to do 2 times a week to avoid the big peaks and troughs. So, disadvantages to testosterone injections. One, patients have to understand aseptic technique. Not huge to train them on that and explain it, but it is a factor. Um, it also requires some dexterity. So as patients age, using an injection, especially an IM injection, it can be a little challenging. So those are factors we want to keep in mind. And of course, sticking a big needle into your body hurts. The other thing about an IM injection is it does require muscle activation. And because of some of these factors, you can see some non-compliance. Again, I really like subcutaneous injections. Um, Using a much smaller needle doesn't hurt nearly as much. It can still be somewhat difficult for patients just from a dexterity issue, but again, see better levels and much easier injection. So again, starting with the injections and dosing. I'd say generally speaking with test, you see around 100 milligrams a week, probably more often than not. Certainly you can go lower than that. Um, I still see doctors using an every 2 week dose, so 200 milligrams every 2 weeks, which is just crazy. Your peaks and troughs are all over the board. Um, a lot of patients, again, the IM, man, if you are at all needle phobic, boy, that's a 1 inch to 1.5 inch needle, and that can be pretty scary. Now, again, the sub-Q injections, like I mentioned, take whatever your weekly dose is, divide it in two, and do whatever, Sunday, Wednesday, or Monday, Thursday dosing so that you don't get the big peaks and troughs. Um, and it doesn't hurt so much. It's an easier injection for patients. Getting into some of the topical products. So, there's a lot of trade products out there, the creams and gels. The advantages of these, easy to apply, relatively easy to adjust the dosage. There's no needles involved, so patients like that. You can vary the administration site, use various areas of the body where you've got some nice clean skin and lots of good absorption. Um, from a compounded perspective, we can combine our target hormones together so that it's only one application per day. Again, with a topical, you get the advantage of bypassing first pass metabolism as well. In terms of the benefits of the compounded products, generally speaking, much less expensive. Even when insurance covers the trade products, a lot of times our compounds are still less expensive. One of the big things that I advocate is the fact that we can make our products so much more concentrated than what the trade products are. So, with a trade product, you're applying maybe 5 ml, and with a compound, maybe 0.5. So again, that's a great option. Another great option with the compounded product is the options of all the different bases. Everything from kind of a standard hormone cream to things like the Atravus gel to increase the absorption, or if there's reactions to different bases, we can change that around. So disadvantages to topicals, big one, you hear it all the time, transference. Well, and this is really easy to understand, especially with the trade products, like I mentioned, the 5 mLs, you have to apply it to your shoulder blades or whatever. So large skin area, increased risk of transfer, increased risk of any kind of dermatological sensitivity. Some of those products, even, you get into whether it's once a day or twice a day application, multiple times a day, definitely you're going to see greater chance of non-compliance with patients. The disadvantage with, of course, the trade products, especially if you're getting any kind of a sensitivity reaction or response or allergic response, you're stuck with it. You don't have any option as far as what base to use. In terms of a dose conversion, pretty simple stuff. Topical testosterone, using about 50 milligrams a day is equivalent to somebody who's doing 100 milligrams once a week. I am. That's pretty simple breakdown in terms of how to proceed. And again, the benefit here, compounding the different hormones into one, so that, again, we're going to improve compliance, we're going to reduce the cost. So the benefits to the patient are many-fold, but better outcomes, better compliance, less expensive. Testosterone pellets, which we had available, a little bit difficult to come by right now. So it's crystalline testosterone. It is implanted under the skin. Usually, and again, I'm basing this off of a lot of patients that I've worked with over the years, but due to insurance, a lot of times, the insurance will limit to 6 of the 75 milligram testapels. So you'll see anywhere from a 450 milligram to about a 600 milligram initial dose for a lot of patients. Patients that love this love it because it's convenient. It's 3 or 4 times a year they go in, they have the pellets inserted, and they don't have to do anything other than that. So it does have the sustained release. There's no risk of transference. It bypasses the first pass metabolism. The levels are fairly consistent. That's not to say that it's completely linear, but for the most part, they're pretty good, and especially once you've got the proper dosage established. From a compounding standpoint, as opposed to the trade products, we can compound various strengths and ingredients into a single pellet, whereas the trade products, it's a set strength and only one hormone available. And the negatives to the pellets, well, again, it's inserted. It's an invasive procedure. So yes, there's a little bit of a local anesthetic used. There's a small incision. You can get some pain. There is a minor risk of infection. There is a larger risk of a reaction, whether that be just a simple dermatitis or a foreign body immunological response. There's also the risk for scarring. This can lead to having to really move those sites of the implant around. In some patients, you run into incidents where you kind of just run out of good spots to work with. Another thing that I will mention, like I said, they are sustained release, but that does not mean it's linear. You typically do get a higher level at the beginning, immediately after insertion, and then there's a trough further on down the line. So, what are the options as far as oral therapy? Advantage, easy to do, easy to use. Disadvantage, really not great for guys for testosterone. I mean, the only available thing are the trade products, the testosterone and decanoate, and we're not compounding that, and insurance isn't going to cover it for majority of patients. Very limited in terms of who can really get that. There are some issues with monitoring just because you've got very frequent dosing due to short half-lives. There's going to be issues with metabolites, issues with liver toxicity, compliance, because the doses start at twice a day and then they go up from there. And again, as I mentioned, patients who this is approved for really fall into very specific categories. So it's not really going to be your typical TRT patient. Sublingual troches or rapid dissolve tablets. Again, easy to use in terms of advantages. Easy to use, easy to adjust, wide range of dosages, can do combination therapy. Not great for TRT. Why? Well, quick absorption, quickly metabolized. So that means, very short duration of action in the body. You might have to do 3 or 4 doses per day. Probably a good bit of the medication being swallowed, which it's going to deactivate. It's going to chew up that testosterone in the system. Plus, you're going to get the side effects going through the liver and the first pass metabolism. Where I do like the sublingual is using it on a PRN basis, especially with sexual medicine. We see this as a great option for libido. I call it the Friday night special because you can use one of these products. It's quickly absorbed and then quickly metabolized out. There's no depot effect from it. So just for that quick boost, and again, it could be also appropriate just for generalized fatigue or, for improving exercise tolerance. But again, I kind of focused more on just the sexual activity. And the last option, which again, not really a compounded version, but the trade products out there, the transdermal patches. Again, easy. They're convenient. Slap it on. They are typically going to release over a few days. Dosage are reasonably easy to adjust. It's bypassing first pass metabolism. The negatives to this, although dosages are relatively easy to adjust, there are very limited doses available. They're single entity, so single hormone products only. You run into a lot of problems with the patches staying on. So adherence, patients trying to reapply. And then, like with anything, with any kind of an adhesive, there can be sensitivities. So definitely something to be careful with. Effective? Yes. Practical? Probably not for most patients. Bottom line, a lot of options, and fit the therapeutic option to the patient on what they want and what they need. And again, a lot of times you can look at it and say, well, we're going to be using multiple components, and if we can put that into one dosage form, and that could be the be-all end-all in terms of the answer for them, just because offering a single product is going to improve compliance and their overall outcome. Kind of wrap it up. As with most therapies, number one thing, do your due diligence. Get in there, find out what's going on with the patient, what are their risk factors, what are the comorbidities, what's their history. If it's TRT, are they testosterone naive? Have they ever used it before, or do they have a history with it? Start low with therapy and work your way up. Don't make real rapid adjustments and don't jump in being overly aggressive. Keep in mind that each patient is unique, so individualize their treatment and your approach. Kind of build a program for your patient. And of course, the labs are extremely important. You always want to be watching the numbers. However, treat the patient. It's not just about the numbers. It's, what is the patient's subjective report? How are they feeling? And, are you really achieving the therapeutic goals that you're looking for? That being said, thank you so much for listening in. I appreciate the time. And this is us. That's how you get in touch with us. And I encourage, if you've got questions, either reach out directly to Revelation or to any one of our network pharmacies. And thanks again. Have a great day.